Good morning, everyone. Today we're going to discuss nursing management of pregnancy at risk, and we're going to talk about selected health conditions and vulnerable populations. So pregnancy and childbirth are exciting yet very complex facets within the continuum of women's health. Ideally, the pregnant woman is free of any type of condition that can affect her pregnancy, but in reality, many women enter pregnancy with a multitude of health-related or even psychosocial issues that can have a negative impact on the outcomes of her pregnancy. Many pregnant women express the wish of, I hope my baby is born healthy, because they know that anything can happen during their pregnancy. Nurses, in turn, can play a major role in helping this become a reality because we can educate the woman before they become pregnant. So we can educate them on diets, on lifestyles, on things that may have a negative outcome of their pregnancy or negative aspects during their pregnancy. So conditions like diabetes, cardiac, respiratory disorders, anemia, autoimmune disorders, and specific infections can frequently be controlled through close prenatal management so that their impact on pregnancy will be minimized. And that's the goal of prenatal care, essentially. We will address common conditions that can have a negative impact on the pregnancy and about special populations that are at risk. All right, so first of all, we're going to discuss diabetes mellitus. We're going to discuss the pathophysiology of diabetes, the screening tests that we do, therapeutic management, nursing assessments, and nursing management of the pregnant patient with diabetes. Okay, so diabetes is a complex and progressive disease that has major societal and economic impact. A reduced sensitivity to insulin in the liver, muscle, and adipose tissue, and a progressive decline in pancreatic beta cell function is basically what leads to the impaired insulin secretion, which eventually results in hyperglycemia, which is the hallmark of diabetes. Now, with insulin, there is a deficiency of or a resistance to insulin. This alteration interferes with the body's ability to obtain nutrients for fuel and storage. So the current understanding of the pathophysiology of gestational diabetes includes two key components. These are the existence of pancreatic beta cell dysfunction prior to pregnancy and the unmasking of this problem by the development of insulin resistance during pregnancy, which requires enhanced insulin production to maintain normal blood glucose ranges. So, normal pregnancy is characterized by increased peripheral resistance to insulin. This occurs in every pregnancy, and a compensatory increased insulin production results in the beta cell dysfunction before pregnancy may be unable to mount a sufficiently robust beta cell response to pregnancy-mediated insulin resistance. So essentially, what's happening is that if the patient has some prior beta cell dysfunction. Maybe not completely. Maybe they're just pre-diabetic. Maybe they're borderline, or they don't even know it prior to pregnancy. Now, when they get pregnant and we have the insulin resistance that's due to the placental hormones of HPL, that then in turn your body, the pregnant body, will then have to supplement and start to increase more insulin because it's seeing that it's not getting to where it needs to get to. However, if the patient, like I said, already has some type of prior dysfunction, be it all not causing her to have diabetes prior to pregnancy, but maybe causing her to be borderline, then now that she needs more beta cell production of insulin, she can't really produce more. So because she can't produce more, and we have a resistance to the insulin that she is producing, then that's when the patient becomes gestational diabetic. And like I said, pregnancy is accompanied by this insulin resistance, and this is automatically mediated by the placental secretions of your diabetogenic hormones, and that's your HPL, which is your human placental lactogen. These and other metabolic changes that occur during pregnancy ensure that the fetus has an ample supply of nutrients, and that's how the baby is able to feed through the placenta, because we have these placental secretions in order to make sure that the insulin doesn't keep bringing down the mother's blood sugars, that the blood sugars on the mom stays high enough to be able to cross the placenta and feed the baby. So now we talk about screening. All right, let's go back for a minute, and I just want to reiterate or just bring up a certain point. If a pregnant woman has pre-gestational diabetes, let's say that she's pre-diabetic, she's already a diabetic prior to pregnancy, or even if she develops gestational diabetes, the profound metabolic alterations that occur during pregnancy and that are necessary to support the growth and development of the fetus are greatly affected. So if she comes on board with diabetes already, or she develops gestational diabetes, the way that the baby is going to grow is going to be completely affected, because now we're not going to get, or we're going to have issues with that glucose that's going through the placenta. In pregnancy, placental hormones cause insulin resistance at a level that tends to parallel the growth of the fetal placental unit. As the placenta grows, more placental hormones are secreted. Human placental lactogen and growth hormone, which is your somatotropin, increase in direct correlation with the growth of the placental tissue, rising throughout the last 20 weeks of pregnancy and causing insulin resistance, meaning that mom is producing insulin, but the lock, that means the lock to open up the cells so that the insulin is the key, and so that the glucose can then travel into the tissues, isn't getting there. It's been changed, and so that's causing the resistance. In pregnant women without diabetes, the pancreas can respond to the demand for more insulin, for more increased insulin production to maintain normal glucose levels throughout the pregnancy. So if she doesn't have a problem with her pancreas producing more insulin, then she's going to produce more than what she needs in order to bring down her glucose levels. But if she has an issue, that's where you're going to have a problem with the mom becoming diabetic. So over the course of the pregnancy, insulin resistance does change, peaking in the last trimester to be able to provide more nutrients to the fetus. This typically results in a postpartum pre-prandial hyperglycemia. So meaning about 2 hours after they eat, their blood sugars are high. Although some women also have an elevated fasting blood glucose level. So they could even be elevated even after first waking up in the morning. Women with diabetes cannot accommodate the increased insulin demand. Glucose levels rise as a result of insulin deficiency, leading to hyperglycemia. So subsequently, the mother and her fetus can experience major problems. And the list of these problems is going to be available to you in your chapter on table 20.2. And you'll be able to see the list of different types of complications or major problems that can arise from diabetes. Okay, so now that I covered that and I wanted to bring that point up, now we could talk about screening. Okay, so let's talk about screening. ACOG recommendation is to perform a risk assessment on all pregnant women at their first prenatal visit, and additionally screening of all high-risk pregnant women, again at 24 to 28 weeks or earlier if risk factors are present. So the criteria for non-screening, so these are patients that we would not screen, would be patients that have no history of glucose intolerance, patients that are less than 25 years old, have no family history or first-degree relative of diabetes, patients that have no history of poor obstetric outcomes, and patients that are not from a high-risk ethnic or racial group. And these would be Hispanics or African Americans. If early screening is high, if it's done and it's high, then most likely pre-gestational diabetes is present. So meaning that if you're screening them in the early first trimester and their blood sugar is high or their results are high, then most likely they were diabetic before even getting pregnant. Maybe they just didn't know about it. And this means that the fetus is at higher risk for congenital anomalies, because during that first trimester is when things are developing, when all the organs are developing in the fetus. And if blood sugars are elevated and uncontrolled, then the fetus will result in congenital anomalies. So how do we screen our patients? So screening involves doing a 75-gram 1-hour glucose challenge test. We do this between 24 and 28 weeks. Once we give the 75-gram oral glucose load, then we wait an hour and we measure the glucose level through a serum sample 1 hour later. If the level is above 140 milligrams, which is your cutoff point, it is considered abnormal. If it is abnormal, meaning that it's higher than 140 milligrams, then that means that a 3-hour glucose tolerance test needs to be done. A 3-hour glucose tolerance test basically involves the same type of procedure. However, these patients do need to be fasting, and instead of a 75-gram oral glucose load, they get a 100-gram load of glucose. So what we do is the same thing. They come in fasting. We do a blood sugar serum. Then we give them the load of 100 grams, and then we test their blood at every hour for 3 hours. So at the 1 hour mark, at the 2 hour mark, and at the 3 hour mark. And then your lab values that are important would be if the glucose is less than 92 for a fasting is considered normal. So above 92 would be considered abnormal. At the 1 hour mark, it should be less than 180 milligrams. So only less than 180 would be considered normal. At the 2 hour mark, it's 153, which is your cutoff. And at the 3 hour mark, it's 140 milligrams. Diagnosis of gestational diabetes can be made only after we have an abnormal result from your glucose tolerance test. And really, we prefer it to be the abnormal values from not just the 1 hour, but from the 3 hour. And we usually need 2 abnormal results to confirm a diagnosis in the 3 hour to be considered gestational diabetes. Now, yes, there are some physicians that are much more conservative, and if they have even 1 abnormal in the 3 hour glucose challenge, they will consider them gestational diabetic, and then they will start them on nutritional counseling and nutritional treatments. And we'll talk about treatments in a second. So we also have now a more stricter control screening, which is now including the hemoglobin A1C. And this has been adopted by ACOG due to the evidence that diagnosing and treating even mild gestational diabetes does reduce the morbidity for both the mother and the infant. And so we try very hard to make sure that our moms and our babies are protected. So now we get to therapeutic management. And pregestational diabetes is a very significant public health problem. It does increase the risk for structural birth defects affecting both maternal and neonatal pregnancy outcomes. So if a mom comes into the OB already being a diabetic, we hope that she comes to us with her being at least very well controlled in her pregnancy. So achieving good metabolic control during the period prior to conception is essential to reducing the congenital malformations that can occur in pregnancies complicated by diabetes. So we really hope that she comes to us way much in good control during the for her first prenatal visit. So the primary goal of care is basically to maintain glycemic control and to minimize, of course, then the risks of the disease on the fetus. So if we maintain good glycemic control, then we will reduce the risk to the fetus. Key aspects of treatment are going to include your first step, which would be nutritional management, which will include exercise, eating the right foods, eating the certain foods at the best times. Then it will include insulin regimens if it's needed, and close maternal and fetal surveillance during the pregnancy. So remember, this is a disease that will affect the pregnancy outcome. It will affect the status of the fetus. So this will make mom a high risk pregnancy. This will make her pregnancy at the moment, once we've diagnosed her, a high risk pregnancy. When we're using the glucosylated hemoglobin or your A1C level, the measurement gives us an average glucose level during the past 100 to 120 days. And really our goal is to keep that hemoglobin A1C level to less than 7, which will indicate very good control. A value that is more than 8 will usually indicate poor control, and then it basically warrants intervention. And so again, therapeutic regimens, we always are going to start with lifestyle modifications. So meaning, diet, exercise, eating the right foods, when to eat them. We'll send them to a nutritionist or to a dietary consult. Nutritional changes, again, we're going to teach them what they can and cannot eat, how they should eat, and when they should eat it. Encouraging physical exercise, physical activity, even if it's just walking 3 days a week, is going to increase her glucose control. And then if we have to, because her levels do not stay controlled, then we consider pharmacologic intervention, which will include giving her insulin or oral agents. And we do give oral agents during pregnancy. Pre-gestational diabetic pregnant women have up to about 9-fold increase in birth defects compared with the rate seen in non-diabetic pregnancies if she does not have good glycemic control. So preconceptional counseling, so if we get these moms in prior to them getting pregnant, if they're coming to the OBs or to your nurse practitioners or to your midwives for birth control, and now they say, I don't want to use my birth control anymore because I want to get pregnant, then this is when we want to start preconceptional counseling. It's important in helping to reduce the risk of congenital malformations. So the most common malformation associated with diabetes occurs in the renal, cardiac, skeletal, and central nervous systems. Since these defects occur by the 8th week of gestation, preconceptional counseling is critical. So basically, before she even knows that she's pregnant, or even by the time she knows that she's pregnant at 8 weeks, if those 8 weeks prior to her finding out that she's pregnant, if she hasn't been very controlled in her blood sugars, her baby can already have significant malformations. Gestational diabetes basically is defined as glucose intolerance with its onset only during pregnancy. And that's usually when it's first detected. We want to maintain tight control for pregnant women. So women who don't have diabetes, we want them to be able to have a consistent fasting blood sugar somewhere between 60 and 90. And a 2-hour postprandial exam blood sugar of between 60 and 120. And most women do have this. This is going to keep helping to reduce the baby's risk of becoming macrosomic. And macrosomic is having your big baby. Nutritional therapy is the cornerstone of the therapy for women who have gestational diabetes. That's what we start with every pregnant mom who has gestational diabetes. So we encourage physical activity, nutritional therapy. Maybe with these types of changes, this is all that they need in order to maintain a tight glucose control. And we're going to have them doing their blood sugars 5 times a day. We're going to have them logging what their blood sugars are so that we can see what their blood sugars are and see how well they are controlled. Pharmacologic therapy really is going to be needed when tight control cannot be achieved with diet and exercise alone. We do give them insulin, oral medications is what we use to maintain that control. Glyburide and metformin have been found to be safe in pregnancy. And usually if we need to start pharmacologic therapy, we're going to start with oral agents first. And those are our go-to medications. So glyburide and metformin are your go-to meds. And then if those don't maintain blood sugar, then they do insulin. During labor, IV with lactated ringers is usually what's given. And then the glucose is usually monitored every 1 to 2 hours throughout the labor to help reduce the likelihood of any type of neonatal hypoglycemia. Remember, her blood sugar can be very erratic during labor because of the hormones and the activity of labor. So we want to make sure that the baby doesn't get hypoglycemic. So we're going to monitor her blood sugar every 1 to 2 hours. ACOG does recommend that women with gestational diabetes by a 3-hour glucose tolerance test receive nutritional counseling from a registered dietitian. So if we screened her at 24 to 28 weeks and we found out that she had 2 abnormal values in her 3-hour, ACOG recommendations, which means that the standard of practice is to do nutritional counseling by a registered dietitian. Like glycemic control, regardless of whether it involves diet, insulin, or any type of oral agent, will lead to fewer cases of shoulder dystocia, hyperbilirubinemia that requires phototherapy, nerve palsy from shoulder dystocia, or bone fractures from shoulder dystocia. It will reduce fewer cases of large for gestational age babies, and of course fetal macrosomia, so an even larger baby. So this is why it's so important to be able to make sure that our moms have tight glycemic control. So as a nurse, we say, okay, these are the things that we want to follow. Now, as a nurse, what is it that I do for these patients? So we start off with assessments. Again, remember, nurses assess, right? So we're going to start with assessments, and you're going to, at that first prenatal visit is when we're going to do our main assessment. So we're going to do our history and physicals. We're going to do specific lab work and any type of diagnostic test. If they have any type of history of pre-existing diabetic conditions. So this is when we're asking, is our mom a diabetic? Is she not a diabetic? Does she have a first degree relative that's a diabetic? Does she have any of the risk factors? If she has a pre-gestational history of diabetes, these women we're going to treat a little different. So we're going to do a history of their pre-existing diabetic condition. So how long have they been diabetic? What's been managing them? What's their progression of their disease? And what is being used to manage them currently, or what was being used to manage them prior to pregnancy? Have they had to make any dietary adjustments already by the time they come to us? Is there any presence of vascular complications? Remember when we talked about diabetes will have already caused certain vascular changes if they've had long-term diabetics with poor glycemic control. So is there any of these complications already? And what's their current insulin regimen if they have one? Must be very knowledgeable about her nutritional requirements and assess the adequacy and pattern of her dietary intake. So most moms who come in already diabetic, if they've been diabetic for a long time, they know what to eat, when to eat. They've been through this. They already have a history of being diabetic. So they're going to be able to know what they need in terms of diet or exercise or even their insulin regimens and when to treat themselves. Throughout the prenatal visits, we must assess their knowledge of her disease, including any signs and symptoms of hypoglycemia, diabetic ketoacidosis, and how to give herself insulin. So we're always making sure that we are assessing. So for our pre-diabetic moms, our pre-gestational diabetic moms, we're asking them, okay, are you feeling any different? Are you changing your regimen? Most of these moms are probably already being evaluated or have been being evaluated by a primary care physician or an endocrinologist with their diabetes. So they've come to us already with some type of pre-existing history or treatment. For our moms that are discovered during their pregnancy, that they found that they have gestational diabetes, these moms, their assessments, every time they come, we're going to ask them for any clinical presence of the 3 Ps. So are they drinking too much? Are they peeing too much? Are they eating too much? All of those things. Do they have any history of any previous medical conditions? Chronic renal disease, obesity, chronic hypertension, those things we need to assess on these gestational diabetics. And again, we want to assess for any risk factors for gestational diabetics. So do they have that first degree relative? Are they already pre-diabetic? Were they already having some type of pre-existing conditions? Are they from the high risk ethnic groups or racial or cultural groups that are more prone and more at risk for getting diabetes? So we're going to be always assessing these moms and asking them questions. So really, maternal and fetal surveillance is the key to having a positive outcome. And we want to make sure that we always reinforce all the verbal instructions with some type of written material as well. Frequent encouragement is also going to be needed to assist the woman in her lifestyle changes, because remember, especially if she's a gestational diabetic, she never had issues with her blood sugars before. She never had to do all of these blood sugar checks, and now we're expecting her to check her blood sugar 5 times a day, change the way she eats, do exercise. So a lot goes into this diagnosis. Risk factors for gestational diabetes are going to include previous infant with some type of congenital anomaly, history of gestational diabetes, or polyhydramnios with a previous pregnancy, family history of diabetes, medications such as corticosteroids or antipsychotics, 35 years or older, polycystic ovarian syndrome, multiple pregnancies, previous infants weighing more than 9 pounds or the 4,000 grams. If mom is obese, any previous unexplained fetal demises, patients that are hypertensive before pregnancy or in the very early stages of pregnancy, recurrence, yeast infections that do not respond to any type of treatment, Signs and symptoms of glucose intolerance, so they're complaining about the 3Ps. And again, presence of glucose or protein in their urine. These are all going to be different risk factors that we will either be assessing for or asking them about during each of their visits. Diagnostic testing that we do, again, results of lab and diagnostic tests will help us to provide valuable information and maintain maternal and fetal well-being. So these moms, again, they're now going to be considered high risk, and they're going to be getting non-stress tests regularly. They're going to be checking their blood sugars 5 times a day. They're going to be getting a hemoglobin A1C once every 3 months or so. So these are types of the diagnostic tests that we will be doing. Surveillance wise, again, we're checking for protein, for nitrates, and for leukocytes in their urine. We're checking for ketones in their urine, glucose in their urine, kidney function. Every trimester is going to be evaluated by doing a creatinine clearance and protein levels. We might even do eye exams in the first trimester to help evaluate their retina status for any type of vascular changes. And again, the hemoglobin A1C every 4 to 6 weeks to monitor for their glucose trends and what they've been. Fetal surveillance that we're going to include, again, ultrasounds to watch for fetal growth, for fetal movement and activity, to see how well their amniotic fluid levels are doing, and to validate the baby's gestational age, to make sure that we are confirming how old that fetus is. We might do alpha fetoprotein levels, which will help us to look for any type of congenital anomalies. We will do fetal echocardiograms, make sure that we're ruling out any cardiac anomalies on the baby. We'll do biophysical profiles to determine the fetal well-being and the condition of the placenta. And again, non-stress tests, usually weekly by the time they get to over 28 weeks. And these are basically all of your nursing assessments that are done with these gestational age moms. Because this is important. This is what's really going to help to monitor fetal and maternal well-being. Again, nurses will play a very pivotal role in realizing a positive outcome in the pregnancy. And in order to be able to get and maintain a healthy newborn and a healthy mom, this is part of all the nursing management. So for visits, again, every 2 weeks up to 28 weeks, and then 2 times a week until the time that they deliver. They're going to be considered high risk. So these antepartum visits will occur much more frequently than a normal non-complicated pregnancy. This provides the nurse with numerous opportunities for ongoing assessments and education and counseling. So we're going to have plenty of time to be able to talk to our patients. Promoting optimal glucose control. Again, we want to review her glucose log. We want to look at her labs, see her results. If she's on insulin, see if we need to change the doses. If we see that her fasting is higher, and maybe we need to change her nighttime dose, those kind of things. We want to obtain a urine specimen to check for glucose and for protein and ketones. And again, we want to ask her about any hypoglycemic episodes. Has she had any times where she felt like her blood sugar dropped suddenly? Or if she's on insulin, did she not eat enough to bring her insulin come down? For women who are in labor, again, we want to adjust the IV flow and the rate to supplement any type of regular insulin that we might have to give her during labor. We want to monitor her blood glucose levels every 1 to 2 hours, monitor her fetal heart rate patterns, looking for any type of abnormalities in her fetal heart rate levels. We want to assess her vital signs every hour And again, we want to usually put in a Foley catheter because we want to make sure we're monitoring her urine output adequately. Postpartum wise, we're going to monitor her glucose levels usually every 2 to 4 hours for the first 48 hours. And then determine whether she still needs to be on her pharmacologic treatments if she was on any. This kind of like will change. So like for our type 1 diabetics, like our moms that came in with pre-gestational diabetes, their insulin needs are going to really drop dramatically within those first 24 hours. They're not going to need as much insulin as they needed during their pregnancy. So they're are going to be really have to be monitored. We want to encourage breastfeeding on these moms to help to maintain that glucose control. And we want to be able to continue giving her IV fluids in postpartum. Most physicians, postpartum patients that are just gestational diabetic and are just diet control, they don't even get a spot glucose check postpartum. Once we deliver the baby and the placenta is delivered, the patient is basically cured because the source of the insulin resistance, which is the placenta, is gone. And so then most of these moms are just fine right after delivery. Infant-wise, we want to be able to monitor the baby for macrosomia. We want to be able to monitor the baby for respiratory distress syndrome. Hypoglycemia is going to be a big one for these babies. Hypocalcemia, hyperbilirubinemia, and a variety of congenital anomalies are what we're going to be assessing the babies for. Basically, we want to make sure that we're also preventing any types of complications. So during our visits, it's the time that we ask about signs and symptoms of complications at each of the visits. We want to, again, assess their blood pressures, look for any changes, evaluate for proteinuria, all of the things that we would normally do on a high-risk patient. Measuring fundal heights to make sure that the baby's not growing too much. Looking for polyhydramnios. So if her fundal measurement doesn't add up to how many weeks that she is, then it could either be a big baby or a lot of fluid. So we need to look at that. We want to make sure that she's doing fetal kick counts at home so that she knows that the baby's active. Remember, an active baby indicates fetal well-being. Encouraging follow-up with serial ultrasounds for fetal growth. And performing NSTs and biophysical profiles are going to be very important. And always, again, nurses assess. Nurses are the ones who are going to be that diligent overseer of being able to maintain and really work towards having a healthy mom and a healthy baby. So preventing complications and providing education and counseling are always going to be the nurse's role. It's always going to be part of what the nurses need to do. Okay, so now we're going to discuss cardiovascular disorders. Despite an increase in awareness of a wide range of health concerns, every minute an American woman dies of cardiovascular disorders, and more than 1 in 3 women is living with some type of cardiovascular disorder. Approximately 3% of pregnant women have cardiac disease, which is responsible for about 10 to 25% of all maternal deaths. The prevalence of cardiac disease is increasing as a result of lifestyle patterns, including things like smoking, cigarette smoking, diabetes, and high levels of stress. As women are delaying childbearing more and more, the incidence of cardiac disease in pregnancy will continue to increase. The cardiovascular adaptations during pregnancy are well tolerated by the normal heart, but may also unveil some type of undiagnosed or underlying heart disease, or it may tip the hemodynamic balance and lead to decompensation in those with already existing heart disease. So, because we are fixing and correcting many more cardiac issues when patients are young, these women are also then expecting to have be able to have normal pregnancies and delayed childbearing, which makes things even worse. So any women with some type of pre-existing cardiac disease, either it was when they were born or as they got when they were young, will always have some type of potential risk during pregnancy. So congenital and acquired heart disease. So congenital heart disease now constitutes nearly about half of all the cases of heart disease encountered during pregnancy. Classic symptoms of heart disease will mimic common symptoms of late pregnancy, such as palpitations, shortness of breath with exertion, occasional chest pain. Few women with heart disease die during pregnancy, but they are at risk for other complications such as heart failure, arrhythmias, or strokes. Congenital and acquired often involve structural defects that are present at birth, but may not be discovered at that time. So they may be discovered later on when the mom is a child or a young teen. Until recently, women with congenital heart disease did not really live long enough to bear any children. Today, because of the new surgical techniques to correct these defects, many of these women can complete a successful pregnancy, most of them at relatively low risk when appropriate counseling and optimal care is provided. So a woman's ability to function during the pregnancy is often more important than the actual diagnosis of the cardiac condition. The following is a functional classification system that was developed by the Criteria Committee of the New York Heart Association in 1994 that based on past and present disability and physical signs. So it provides a very simple way of classifying the extent of heart failure by placing people in one of four categories based on how much they are limited during physical activity: normal breathing and varying degrees of shortness of breath and or chest pain. So your class 1 is your patients who are asymptomatic. They have no limitations with any physical activity, no objective evidence of cardiac disease. Ordinary physical activity does not cause any undue fatigue, palpitations, dyspnea, or chest pain. Your class 2, they're symptomatic. They have dyspnea and chest pain with increased activity resulting in slight limitations of physical activity. So they are comfortable at rest, but ordinary physical activity will result in fatigue, palpitations, dyspnea, and anginal pain. This is where we have women that have minimal cardiovascular disease present. Your class 3 are your symptomatic patients with fatigue and palpitations with normal activity, resulting in marked limitation of physical activity. So they are comfortable at rest, but less than ordinary activity causes them to have fatigue, palpitations, dyspnea, and anginal pain. These women show moderately severe CVD presence. And then your class 4 are your symptomatic at rest or with any physical activity, resulting in the inability to carry on any type of physical activity without discomfort. So these symptoms of heart failure or the anginal syndrome may be present even if they're at rest. If any physical activity is undertaken, discomfort is increased. These patients have severe CVD present, and these women usually are unable to have a successful pregnancy. So with these women that have congenital and acquired heart disease, this is going to be your most common symptom, your most common complication. Your symptoms that you're going to look for are edema, dyspnea, and tachycardia. So these women, we of course would have to monitor very closely. We're going to monitor the mom as well as the fetus. Teaching becomes very vital with these patients. This becomes also a collaborative care patient, so where your OB is not the only one taking care of this patient. This patient is being followed by maternal fetal medicine as well as a cardiologist. Teaching them becomes very vital with these patients. So you want to teach them about nutrition, about how to avoid infection, how to avoid stress or excessive weight gain. If we have to undertake medication therapy, we're going to give these moms prophylactic antibiotics for any type of invasive procedures. You're always going to be doing a risk assessment on these moms. So ideally, moms or women with a history of congenital or acquired heart disease should consult their healthcare provider and undergo a risk assessment before becoming pregnant. We would like to be able to at least be able to assess and kind of know what we're getting into before the pregnancy starts. The risk assessment must consider the woman's functional capacity, her exercise tolerance, her degree of cyanosis, which medications are needed, and a history of arrhythmias. So basically that's all you're really going to have to know with when it comes to women with acquired or congenital heart disease. We're not going to go into any other further detail. It's really just kind of brushing the surface when it comes to heart disease. So now we talk about infections. We're going to discuss infections that will affect the outcome or can affect the outcome of the pregnancy. So these will include cytomegalovirus, rubella, herpes simplex virus, hepatitis B, group B strep, and toxoplasmosis. Okay, so we're going to talk about cytomegalovirus first. Human cytomegalovirus infects greater than 50% of the human population. Humans are the only known host of CMV, which is transmitted via bodily fluids. It is typically asymptomatic in most individuals. CMV is the most common congenital and perinatal viral infection in the world, and this is also discussed in your book on page 724, on table 20.4. You can look at that while you read this section. CMV is the leading cause of congenital infection, with the morbidity and the mortality at birth and sequela. So it can affect both mom and baby. The risk of serious fetal injury is going to be greatest when the maternal infection develops in that first trimester or early in the second trimester. Leading cause of hearing loss And intellectual disability in the U.S. is going to be due to maternal or perinatal cytomegalovirus. Pregnant women acquire active disease primarily from sexual contact, blood transfusion, kissing, and contact with children in daycare centers. It can also be spread through vertical transmission, so from the mother to the child in utero, which causes congenital CMV. It could be also transmitted during birth or through breastfeeding. There are three time periods, basically, which mother to child transmission can occur. And those are going to be in utero, during birth, and after birth. So most women are asymptomatic and do not know that they even have or been exposed to CMV. Symptoms of CMV in the fetus and the newborn, which is known as CMV inclusion disease, will include symptoms such as hepatomegaly, thrombocytopenia. The infant, the fetus might be IUGR, which is intrauterine growth restriction. They might be jaundice, microcephaly, hearing loss, chorioretinitis, and intellectual disability. So newborns that are asymptomatic at birth may go on to develop late neurodevelopmental sequela, with sensory neural hearing loss being the most common condition that occurs later. Routinely, we do not screen for cytomegalovirus. There is a vaccine. There's no vaccine available for prevention. So, and there's really no therapy to prevent or treat CMV infections. Nurses that basically are responsible for educating and supporting childbearing women that are at risk for CMV infection. And basically it's going to be to stress good hygiene, good hand hygiene, and use of sound hygiene practices. So basically good hygiene all the way around will help to prevent exposure to cytomegalovirus. So we really, it's going to be important to make sure that education for cytomegalovirus is going to be one of your prime preventive treatments. Okay, so now we're going to discuss rubella. Rubella, commonly known as the German measles, is spread by droplets or through direct contact with a contaminated object. The risk of pregnant woman transmitting this virus through the placenta to her fetus increases with earlier exposure to the virus. So when the infection occurs within the first month after conception, about 50% of the fetuses show signs of infection. In the second month following conception, about 25% of the fetuses will be infected. And in the third month after conception, only about 10% of fetuses will be affected. Congenital rubella can manifest with a diverse range of symptoms in the newborn, including congenital cataracts, glaucoma, cardiac defects, microcephaly, hearing, and intellectual disabilities. Preconception care has been defined as a set of interventions that are designed to identify and modify risks to a woman's health or pregnancy outcome through prevention and management. So personal and family history is going to be important to assess in those first prenatal visits, physical exam, laboratory screening, reproductive plan, nutrition, supplements, weight, exercise, vaccines, and injury prevention should be all reviewed with all women, if not during that first prenatal visit, but even when they come in for family planning. Folic acid, a minimum of 400 micrograms per day, should be recommended to all reproductive age women, and as well as proper diet and exercise should be encouraged as well. Women do need to receive the influenza vaccine if planning to get pregnant during the flu season. Rubella vaccines and varicella vaccines as well are important for women to be able to obtain. Education for primary prevention is the key. We want to we do still screen all women at their first prenatal visit to determine their status of rubella, to see, so we do a rubella titer, and as long as it's greater than 1 to 8, that proves immunity, and the patient is said to be rubella immune. If she's not immune, the woman should be vaccinated during the immediate postpartum period, and usually they do get vaccinated prior to discharge after they've had their baby. Okay, so now we're going to discuss herpes simplex virus. General herpes is an STI that's caused by the herpes simplex virus, HSV. There are 2 types, type 1 or type 2. Both types can cause genital infections, although in recent years, HSV-1 has become the prominent cause of genital herpes, but it used to be that general HSV-1 used to stand for oral herpes or herpes of the oral mucosa, while type 2 referred to as genital herpes, but now in recent years that has changed. So it is also just kind of recurrent with the times. Untreated neonatal HSV infection is associated with a mortality rate of 60%, and survivors experience considerable disabilities. HSV is a DNA virus with 2 subtypes, like I said, HSV-1 and HSV-2. Infections occur by direct contact of the skin or mucous membranes with an active lesion through such activities as kissing, sexual, whether it be vaginal, oral, or anal contact, or routine skin-to-skin contact. HSV is associated with infections of the genital tract that, when acquired during pregnancy, can result in severe systemic symptoms in the mother and significant morbidity and mortality in the newborn. Infants that are born to mothers with primary HSV infection have a 30 to 50% risk of acquiring the infection via a perinatal transmission or during birth. The greatest risk of transmission is when the mother develops a primary infection near term and it is not recognized, so because then it ends up being not treated. Most neonatal infections are acquired at or around the time of birth through either ascending infection after the membranes are ruptured or contact with the virus at the time of birth. So the CDC, as of 2015, has recommended that in the absence of active lesions, a vaginal birth is acceptable, but if the mother has active herpetic lesions that are during near or at term, a cesarean birth has to be planned or might be planned. Management for the woman with genital herpes during pregnancy involves caring for her as well as reducing the risk of newborn herpes. So prophylactic antiviral medication is usually given to the mom at the time that she becomes 36 weeks if she doesn't have any active lesions, or if she got her first hepatic lesion during pregnancy, she's going to be treated with antiviral medication and continued on throughout her pregnancy in order to be able to combat the infection and be able to provide a safe delivery for the baby. Herpes is much more common than we think. And during our physical assessments and our history and physicals, and during those first prenatal visits is when we're going to determine whether mom has a history of herpes or not. Like I said, most women before pregnancy who do have herpes are either on some type of prophylactic antivirals in order to be able to prevent active lesions. So usually that will help to reduce the viral load and thus preventing sequela to the newborn. If she does get her primary lesion during pregnancy, it's much more severe case and she has to be followed much more closely during her pregnancy. So now we reach hepatitis B virus. As we know, hepatitis B is one of the most prevalent chronic diseases in the world. It has infected approximately about 2 billion people worldwide, of whom more than 350 million are chronically infected. Life-threatening liver disease like cirrhosis, liver failure, or hepatocellular carcinoma can occur in as many as 40% of people with hepatitis B. Hep B can be transmitted through contaminated blood, illicit drug use, and sexual contact. Sexual transmission accounts for about most adult Hep B infections in the U.S. Acutely infected women develop hepatitis with anorexia, nausea, vomiting, fever, abdominal pain, and jaundice. These are usually the symptoms that the acute disease will present like. In women with acute Hep B, vertical transmission occurs in approximately about 10% of newborns. That means mom giving it to the baby through the placenta. When the infection occurs in that first trimester, and in about 80 to 90% of newborns, when acute infection occurs in the third trimester. So unlike rubella, that their chances of getting congenital rubella decreases as she becomes further along in her pregnancy. With Hep B, the risk of vertical transmission actually increases as she goes further on her pregnancy. So if she gets her acute infection during the first trimester, she's at a lesser chance than if it occurs in the third trimester. The sequela that we will see is without any type of intervention at all. 40% of the infants that are born to women who are positive for Hep B will have chronic hepatitis B by the age of 6 months. Hep B infection during pregnancy is associated with an increased risk of preterm birth, fetal distress during labor, meconium peritonitis, low birth weight, and neonatal deaths in the fetus. The fetus is at particular risk during birth because of the possible contact with the contaminated blood at the time of birth. Treatment that we do follow is by the CDC, also recommended in 2015, that all pregnant women should be tested for Hep B surface antigen, regardless of any type of previous hepatitis B vaccine or screening that may have been given. So this is part of our normal lab work that we do during our initial prenatal care, is that we do a Hep B surface antigen test to determine if they've been inoculated. Screening and a history and physical need to be done on all pregnant women at that very first prenatal visit. If the woman tests positive for Hep B, we expect to administer Hep B immune globulin at the time to the mom. If she's Hep B positive, surface antigen positive. The newborn will also receive Hep B vaccine within 12 hours of birth. So we give the infant also the immune globulin as well as the vaccine. We give the mom who contracted it during pregnancy or is found to be positive inoculation, the immune globulin. The second and third dose of the vaccine are given at 1 and 6 months of age, and that's according to the CDC as well. And the infant then continues with its routine vaccinations. So Hep B is a very big infection that we do see a lot in the hospitals and with our patient population. We are now giving Hep B vaccine to all newborns as part of their normal newborn care. So along with the vitamin K and the erythromycin, which have long been the prophylactic medications for all newborns. Now the Hep B vaccine is also given during that time. So that means it's given within the first hour of birth for all babies, whether mom is positive or not. It's given within that first hour. They found that babies will be more susceptible and easier to prevent any sequela from any undiagnosed Hep B virus that we may not have been picked up or that she may have gotten later on in the pregnancy and it hasn't been disclosed yet. So we reach group B strep. Now, group B strep is a naturally occurring bacterium found in approximately 50% of all healthy adults. Women who test positive for GBS bacteria are just considered carriers. Carrier status is transient and does not indicate the illness. Approximately 25% of pregnant women carry GBS in the rectum or the vagina, thus introducing the risk of colonization of the fetus during birth. So GBS does affect about 1 in every 2,000 newborns in the U.S., and approximately 1 out of every 100 to 200 newborns born to mothers who carry GBS will develop signs and symptoms of GBS disease. The the most common cause of sepsis and meningitis in newborns is GBS, and it is also a frequent cause of newborn pneumonia. Genital tract colonization does pose the most serious threat to the newborn because of the exposure during birth, and to the mother because of ascending infection after the membranes have ruptured. So, GBS colonization in the mother is thought to cause conditions such as chorioamnitis, endometritis, or postpartum wound infections. Treatment for GBS, antibiotic therapy is used to treat it in the urinary tract or the uterus, or chorioamnitis without sequela. So if it's a postpartum delivery, or it's found to be colonized in the wound of a C-section, we do treat it with antibiotic therapy. We do screen all pregnant women at between 35 and 37 weeks of gestation, and we treat them with prophylactic antibiotics during labor if they're found to be positive. We treat them with penicillin-based anti-infectives in order to be able to treat during labor. Pen-G treatment of choice, and it's given IV piggyback 4 hours before, at the minimum 4 hours before birth, so that it can reach adequate levels in the blood and in the amniotic fluid to reduce the risk of newborn colonization. So if the mom is, once she's screened, if she's found to be positive, we usually don't do anything at that point. We wait until she goes into labor. When she goes into labor, she's always instructed that she needs to go into the hospital as early as possible to be able to be treated. We treat her with a loading dose of Pen-G. Then we do repeated doses. So we usually do a 5,000 unit Pen-G, 5,000 units as a loading dose, and then we do 2.5 every 4 hours until she delivers. If we can't give her, if the doctors aren't using Pen-G, then they usually use ampicillin. And again, it's a 2 gram loading dose and 1 gram every 4 hours until they deliver. And we hope to get enough antibiotic in her with a 4 hour minimum, so that way there's ample time for the antibiotic to reach the baby and at least boost the baby's immune system to be able to prevent colonization. Assessment, again, we assess for any risk factors during prenatal care, and we screen them as necessary. Management, again, ensure that pregnant women between 35 and 37 weeks are screened, and we treat them with antibiotics during labor. So now we've reached toxoplasmosis. Now, toxoplasmosis is relatively widespread parasite infection. It is caused by a one-celled organism, which is called your Toxoplasma gondii. It is found really all over the world and can affect any warm-bodied animal, including humans, although the primary host is usually the cat. Cats are the definitive host of this parasite, and they usually shed it in their feces. So when a pregnant woman is exposed to the protozoan, the infection can pose very serious risks to her fetus through the transplacental transfer from the mother to the fetus, also known as the vertical transmission. Transferred usually by hand to mouth after touching cat feces while changing the cat litter box, or through gardening in contaminated soil. It can also be contracted consuming undercooked infected meat, such as pork, lamb, or venison, drinking contaminated water, eating unwashed fruits and vegetables can also transmit the organism, especially if they were grown in contaminated soil. Pregnant women that contracts toxoplasmosis for the first time has approximately about 40% chance of passing the infection to her fetus. If acquired during pregnancy, it means high risk of damage for the fetus. Mom usually will stay asymptomatic, and the transmission will occur to her fetus throughout the pregnancy. So at any time during the pregnancy, transmission can occur. The fetus can develop congenital toxoplasmosis. These are usually evident with symptoms such as low birth weight, enlarged liver and spleen, chorioretinitis, jaundice, intrauterine growth restriction, hydrocephalus, microcephalus, and neurologic damage and anemia. Severity will vary with gestational age. The earlier the infection was passed to the fetus, the more severe the effects are going to be. So basically, the treatment is to prevent and reduce the risk of congenital infection, and we can treat it with a combination of pyrimethamine, and sulfadiazine, and some sulfonamides, and they also will treat toxoplasmosis. The key is, again, it's going to be prevention, and basically what we do with prevention is that we encourage moms that if they do have cats or kittens, that they are not the ones responsible for cleaning the litter box. We say that they can then, transfer that task to another responsible adult or another person in the household, which will then help to reduce her risks as well. If she's a gardener, we make sure that we try to educate her to make sure that she's wearing gloves during gardening, and using preventive methods and good hygiene in order to be able to prevent infection. So really, even though we do have treatments for toxoplasmosis, the key is really to prevent infection completely. That completes the high-risk antepartum section, and please read through your chapters and overlook and kind of use the PowerPoint to be able to help you focus on your readings, and good luck. Thank you.